Hello, sir. Good evening, sir.
How are you? Good to see you.
Hello, sir. Can you hear me, sir?
Yeah, I can hear you. Very good to see you.
Sir. Good evening, sir. Good evening, Prof. Good evening, other panelists. Greetings from Khanna, Northern Nigeria. How many minutes? Okay, 5 minutes. Okay. It's a small talk on critical limb ischemia with some case report. But actually, the case report was largely done by Dr. Edafe. So I'm just going to go over it. He will have more explanation for it later. I will go a bit into the literature and see what we have. The case is that Mr. AD, 68-year-old Nigerian with a non-diabetic hypertension for 20 and 10 years respectively, has been on metformin 1 gram daily, glycyrrhide and amlodipine, as shown on the screen. Luckily, the situation of his foot, left foot for 3 weeks. Has been on aspirin, Celebrex, and Ketanox, but no much improvement. He has no family of similarity in the past, and he was referred for possible intervention. When he was examined, he was noted to be an elderly man in painful distress. He was not pale, he wasn't cyanosed, and he has a hyperpigmented blackish left tooth and poor foot. His pulse rate was normal, 96 beats per minute, but he has absent left posterior tibial and dorsalis pedis pulsations. The pulses are also diminished on the right foot. So test clear, CNS okay. The results came out Doppler confirmed peripheral arterial disease, posterior tibial and dorsalis occlusions. Other investigation were largely normal, first thing was normal. So an assessment of peripheral arterial disease was made. He had intervention, revascularization in Abuja, New Hospital. This is a presentation before the intervention. This is the day 1 after, day 2 after revascularization, and then this is 4 days after. So the limb has cleared. So by literature review, I will go over it very briefly. Time may not be allow me, but as you're all aware, it's a common condition worldwide. And when we say critical ischemia, I mean it's a life-threatening complication of peripheral arterial disease that typically manifests with breast pain and tissue loss. It's common, up to 1 in 10 patients with PAD has CLI, and it has an estimated cost of about $2 billion annually in US, just Medicare alone. So with increasing population, aging population, and increasing tobacco use, other complications, CLI is bound to increase sources. And it's also termed as a chronic limb-threatening ischemia, which is in contrast to the acute limb ischemia. Chronic critical ischemia is like a chronic progressive thing, not occlusion I would see in acute airline. Atherosclerosis that's progressive over time. Hyperlipidemia, diabetes, tobacco smoking, family history, and chronic kidney disease. Other etiologies are shown. Presentation largely is ischemic rest pain, which relieves by the leg elevation, and then patients that are diabetic may have other complications, neuropathy and other things. They may have non-healing wounds in this activities. Findings generally showed diminished absent pulses. The Doppler signals may be monophasic, especially the tibial, prolonged capillary refill time, brittle nails, etc. There is superimposed cellulitis or osteomyelitis in the affected limb. The major diagnosis is using ABI, ankle brachial index, which is mostly widely adopted, available, affordable, and can be done in many outpatient clinics. Patients with DD and OCKD may exhibit pulsely elevated ankle pressures due to calcified blood vessels. And pulse volume recordings also can be used to add, to confirm the ischemia and predict wound healing potential. Diagnosis, basically, as I mentioned, if you have the ABI of less than 4, confirms it. Ankle pressures also, as shown, can be useful. Oxygen pressure also less than 20 to 40 suggests CLI. So there are many classifications done. Those are for one time will not allow me to go into it. There's also a YP classification as shown to correlate with the risk of amputation and treatment outcomes. Prognosis variable depending on the severity and other comorbidities, but yeah, it's about 50%. And many patients may have a concomitant coronary artery disease. So it's multidisciplinary care. I don't have time, sir, but I think I can continue aloud. The treatment is actually a multidisciplinary approach: vascular surgeons, cardiovascular medicine specialists, interventional cardiologists, radiologists, podiatrists, wound care nurses, and physical. But the key component treatment include symptom control, wound care, and revascularization, so that to the aim of salvaging the limb and improving survival and quality of life. Actually, when we say stent control, the most important thing is to keep the limb in independent position, and then you only take analgesics when necessary if the pain is severe. Drugs like lidocaine, gabapentin, ketamine may also be used to optimize patients that have concomitant neuropathic pain. Home management basically is uploading, good nutrition, using non-adherent dressings, and then removal of fibrinous tissues using either sharp or enzymatic approaches. Associated cellulitis usually is caused by polymicrobial agents and warrants broad-spectrum antibiotics as appropriate. I&D, incision and drainage of abscesses, and open to or put amputation may be necessary in wet gangrene to curtail the source control the source of the sepsis. This slide looks bulky. We're just trying to highlight the steps for medical optimization. Main thing is to reduce cardiovascular outcomes and adverse limb events. Typically, you use antiplatelet immunotherapy with aspirin or clopidogrel. That tends to reduce cardiovascular limb-related events. DAPT has a role, although the risk is not clear because of the increased hemorrhagic tendencies when using them. However, drugs like ACE inhibitors for BP control all being advocated. Use of statins also be important to increase survival and improve the efficiency of hospitalization. Importantly, also the patient advised stop smoking, which has been shown to improve limb survival, reduce mortality, and then generate overall cardiovascular adverse events. In terms of counseling for people to stop smoking using either drug supplements like nicotine patches, varenicline, and bupropion, all of them tends to help in smoking cessation. Exercise role is controversial, not very clear. Some guidelines support, some are against it, but generally it should be prescribed with caution. Imaging preoperatively is basically done using Doppler, as in this case. However, there's also a clear role for CT angiography, magnetic resonance angiography, all in order to have clear lesion delineation, so that for proper and appropriate treatment, selection of right approach for intervention. So, patients with renal insufficiency may benefit from prehydration, in order to prevent the risk of contrast nephropathy, which is somehow common in the intervention. So, diagnostic angiography is the gold standard. You require less contrast than CT angiography. It gives you optimal resolution for distinguishing distal lesions and facilitate immediate endovascular treatment. Patients who are candidate to perform as possible PCB post-identified lesion. The Vascular Society of Great Britain and Ireland advocates intervention less than 14 days after diagnosis in all 7 patients, and a short period as possible, less than 5 days in patients that are hospitalized. So there's no need for delay. Delays create more problem and tends to reduce the chances of good outcome. When there's no facility for hospitalization, amputation risks are higher, up to 30% in some studies. Main step for CLA is, of course, I mentioned, is a revascularization, either surgical or using endovascular approaches. Sometimes there is a room for hybrid approach, where you combine the surgery, open surgery, and endovascular treatment. We call it hybrid approach in some situations. Open techniques for vascularization comprise arterial bypass and atherectomy, while endovascular approach mainly is incorporated use of angioplasty, stenting, and/or atherectomy. So the main thing in endovascular is minimally, at least less invasive, unlike open surgery. and it's very good for low extremity, has replaced low extremity bypass in recent days. Even the surgeons are learning and adopting it in most centers. So percutaneous transluminal balloon angioplasty mainly replace plaque, and sometimes you do atherectomy to debulk atherosclerotic material as are the major techniques that are usually employed in vascular approaches. However, newer technologies have emerged. They include putting scoring balloons with abrasive surfaces to assist dissection of heavily calcified lesions. There's also room for cryotherapy and laser atherectomy to facilitate recalculation during angioplasty, disease arteries, and then subintimal angioplasty, which is used across long occlusions through subintimal space. There's also drop-coated balloons, written using of course sirolimus and patric commonly the common ones used. The vessel wall to prevent new hyperplasia and stenosis globally now. Many providers take on the vascular as first treatment option due to high technical and clinical success rates and low morbidity and mortality, and procedure that can be performed even as a patient without necessarily going for GA or admissions. So in the vascular therapy, outcomes have been evaluated in many cohorts, but the general conclusion is they are safe, they are reliable, and they are kind of both safe to the doctor and treatment for the radiation and to the patient, and take less time. Femoral completed angioplasty and bare metal stenosis occlusions in the setting of CLI ranging from as high as 58 to 71% up to, and then 7 to 7% respectively. So hybrid vascularization, if you have multiple lesions, hybrid approaches have been adopted, where you use endovascular surgical approaches, hand to hand. Usually, endovascular approaches are reserved for the inflow lesions, so that while the open surgery used to correct the distal outflow lesions, usually femoral popliteal bypass, whereas the inflow lesions out of iliac are usually managed by endovascular approaches, the inflow lesions. However, limb salvage rates are consistently greater than 8% in 3 years. So, depending on the lesion location, the lesion type, the classification, one can decide to approach the hybrid method, which is, of course, and not all the lesions are amenable to a particular approach. Sometimes you have to consider different approaches for different lesions based on their individual characteristics. So basically, after the revascularization, there's need for surveillance, follow-up, using clinical examinations, repeated ABIs, Doppler ultrasounds, so that at least 3, 6, and 12 month intervals to be able to appreciate and then early diagnose risk stenosis where appropriate. The product symptoms, diminished ocular pulses, decreased ABIs, always increase the chance that the lesion, the vessel has been reoccluded, so there's need for another intervention. So there are also medical adjuncts that have been used aside to the revascularization. Drugs like antithrombotics, which tend to improve the long-term patency and reduce adverse cardiovascular outcomes. Combined antiplatelet and anticoagulant therapy does not really appear to improve patency compared with aspirin alone because of the increased bleeding risk and side effects. And anticoagulation is typically reserved for graft thrombosis mainly, or patients with hypercoagulability. Dual antiplatelet therapy with clopidogrel reduces the need for intervention at 6 months. The optimal duration for clopidogrel ranges from 1 to 3 months or longer, depending on the patient in question. Also, possible combinations include high-dose aspirin and daprodinamol. Also, cilostazol and aspirin have been combined with different results. So these are my 2 slides. Thank you for listening. I wanted to show this slide, but it's like something will not allow me. Memorable picture in Dabat, the boss.
Thank you
sir.
very much. This was indeed very good presentation and covering entire aspects of CLI.